It's my pleasure to introduce our Grand Round speaker today. This is a tradition in our residency of having our chief resident um, give Grand Rounds. So our speaker is Dr. Louise Schultz. She grew up in the Bay Area, did her undergraduate work at Loyola Marymount, and went on to do her medical school at Touro University. And we were lucky enough to have her do her residency with us at PPMC, where she was really a standout resident. And again, really lucky that she accepted being chief resident for this year. And it's been truly one of my pleasures as a new program director to have Louise as a chief resident this year. She's been an outstanding leader and really try to infuse a lot of evidence-based medicine concepts into the residency, and I think you'll really enjoy her talk today.
Thank you, Mari. Good morning, and thank you. I hope that loop video was sufficiently disarming as you were entering into Grand Rounds. This was a cover on the New Yorker last month called The Operating Theater by Malaika Favre for their health, medicine, and body issue. The artist had really wanted to recreate the feeling of losing consciousness while undergoing sedation. I have no disclosures for my talk today. And today, what I would like to talk about is about how women have shaped some of medicine and how medicine has adopted to women over the last 150 years or so. First, why should we care about this? While reviewing some of the literature, and there's a fair bit, I was quite shocked to discover a few things. Female physicians are on par or have demonstrated superior performance in practice style and clinical outcomes. Female physicians are earning approximately 15% less than male physicians across all specialties for the same hours worked. Female physicians continue to be underrepresented in positions of leadership and power. In terms of leadership, I will touch a little bit later on some internal perceptions and external barriers at play. For me, it reminds me of a personal experience being team leader for a code in the ICU. This was about 2 years ago, and I can very vividly remember this and had many more flashbacks actually this past week while I was in ACLS recertification. It was a tense moment. The patient was decompensating. She was bleeding out from a surgery. Only the direct care nurse and I were in the room. It was change of shift kind of later in the afternoon, and she began to have an arrest. The nurse immediately began chest compressions. I called for a code, he called for a code. No one was coming. No, the cart wasn't showing up. No other nurses were coming to help. Nobody seemed to know what was going on. I stepped out in the hallway and I said, "Get me the gosh darn cart." Although I didn't quite use gosh darn and I didn't have such a calm tone in my voice. I can still remember the exact room, the exact nurse, what the patient looked like, and what was going on with the other nurses and the other pharmacists that did eventually show up to the code. But more importantly, what sticks with me and what I remember is the discomfort that I felt in that role of being a leader, in that role of being quite stern and being a bit uncomfortable with that. And I often sometimes will ruminate on that moment and other moments that are similar to that when I have taken that tone or been that stern or been in a position of leadership. I want to provide an overview of my talk. First, I will discuss practice style and specifically decisions, risk aversion, guideline adherence, communication style with patients, as well as clinical outcomes and leadership style. And as I go through my talk, I will be intermittently introducing you to a selection of famous female physicians. It's not appearing. Here we go. The second part of my talk is the effect of medicine on women in terms of burnout and suicide rates, compensation inequality, and career and leadership opportunities. The first female physician I'd like to introduce you to is Dr. Wiley Anderson, and she graduated from the Women's Medical College of Pennsylvania in 1878. She was one of the first black female doctors in the United States. She was a big champion of pursuing teaching after getting her medical degree and worked in physiology and hygiene at the Women's Medical College. In terms of her own practice style, she sought to work with the underserved and started and ran a church clinic in her neighborhood, specifically for women and children that were not getting care. Let's move into women's practice style. There are some notable studied differences in practice style. First, women's practice style is more patient-centered, providing more psychosocial counseling to patients, higher patient satisfaction, higher patient engagement, patients engaging in more positive talk, partnership building, asking questions of their doctors, sharing information in biomedical and psychosocial domains. There's also more counseling on domestic violence, sexually transmitted diseases, family or relationship concerns, and sexual function or concerns were upheld for both male and female patients when they had a female primary care physician. More evidence-based. There's a number, not quite a huge number, but there's a number of clinical practice guidelines and studies reviewing adherence and incorporation of those clinical practice guidelines to patient panels where women have shown some superior adherence and incorporation. And some people theorizing potentially less risky practice style. So I think historically there's a little bit out there in terms of women being more risk averse. It hasn't really borne out in a lot of the financial and business literature, and a lot of that is extrapolated into other fields like medicine. Interestingly, I know I've heard comments, and I know that it's been something where hormonal differences or hormonal effects of estrogen causing potentially different ways of making a decision or something like that. And there have been some studies on the flip side, some loose associations of circulating testosterone and circulating cortisol in men that were linked to riskier career practices in the financial world. So it puts that kind of old sexist adage a bit on its head. Let's look at an example of adherence and incorporation of guidelines. This trial was an observational cross-sectional study of about 2,000 heart failure patients and their current dosages of NYHA recommended therapies. So I'll walk you through the graph. There are 4 distinct graphs, as you can see. Each graph on the x-axis shows male on the left and female patients on the right, and then MD is the doctor, male doctors on the left and female doctors on the right for each of those graphs. The y-axis represents percent of patients on or at targeted therapy dose. The top 2 graphs are ACE inhibitor and ARB therapy, and the bottom 2 graphs are beta blocker therapy. The graphs on the left, these 2, represent if the patient is on the therapy, and then the right is the targeted dose. Looking at the ACE inhibitor and ARB graphs on the top, male physicians were less likely to put their female patients on ACE or ARB therapy and to have them at recommended doses. Female physicians more consistently achieved target doses between their 2 populations, in contrast to the male physicians. Looking at the beta blocker graphs, female physicians were more consistent, again, in initiating beta blocker treatment between their 2 patients, where there was disparity in male physicians prescribing beta blocker therapy to their patients. In summary, male physicians used significantly less medication and lower doses in female patients. Female gender of physicians was an independent predictor of the use and targeted dose of beta blocker therapy for all patients. Here's here's an example of a potential reason why care might be a little bit different by female physicians and being more patient-centric. This was a survey about 4 years ago of 4,000 primary care physicians and any perceived advantages or perceived barriers to providing counseling or preventative care services for their patients. I've selected just a few of the questions from this survey. These are the questions The top bar are the male responders in percent, and the bottom bar are the women responders in percent in their response to each question. As you can see, the bar is longer in the women. More female responders responded favorably to the following statements. I can offer a wide range of lifestyle advice to my patients. I am a well-trained counselor regarding the promotion of a healthy way of life. And I am successful in motivating my patients to adopt a healthier way of life. One other interesting side note on this survey was that male primary care physicians were more likely to mention barriers in daily practice hindering lifestyle counseling. So I've talked a little bit about some differences that have been noticed in practice style, and now I'd like to move into clinical outcomes. Elizabeth Blackwell is another female physician of note. She was the first woman to graduate from a United States medical school in 1849. Here are a couple of reasons why she was rejected from some medical schools. Quote from one of the documents, "As a woman, she is intellectually inferior." When she sought to get into and was ultimately successful in getting into Geneva Medical College, the leadership was actually unsure about this. They decided to put it to a vote of the 150 male students currently in the school, thinking that if even one of them said no, they would reject her application. The students, of course, assumed this was just a hilarious joke, and no one said no, and they unanimously invited her in, and so they accepted her. The last quote from another one of her rejected medical school endeavors was, "We will not furnish her with a stick to break our heads with." And I think that's a fitting quote in terms of discussing that they might have had a point there when we look at some of the data around clinical outcomes for patients when they have female physicians. Some summary points from about a half a dozen studies with particularly adjustment for hours worked, patient population, demographics, and patient acuity. Cohort studies as well as large system-based studies showing lower mortality rates in patients cared for by female hospitalists, lower readmission rates in single-center studies, and equivalent readmission rates in some multi-center studies and other trials. Less ED visits in patients with female primary care physicians. I'll walk through one example here that many people might have seen come out in Journal Watch about last fall from JAMA Internal Medicine. This was a cross-sectional multi-center study of hospitalized Medicare patients over a 3-year period, looking at 1.5 million hospitalizations and 1.5 million patients, with the primary outcomes of 30-day mortality and 30-day readmission rate between male and female hospitalists. This table is a summary of the two primary outcomes, the 30-day mortality and 30-day readmission rate. They outline the number of hospitalizations, and then they show the percent of mortality of patients and readmission rate, comparing female physicians in this column and male physicians in this column, and then the risk difference over here. You can see that there's a number of adjusted models. Some of that was related to hours worked. Some of that was eliminating some other known confounders in terms of patient acuity and that kind of thing, time of year, all of that to try to eliminate as many confounders as possible. Now you might be thinking to yourself, well, I can see those numbers and that difference is not very, very large. It's there, but I don't know what to make of that. And that's true. But if we think about it in terms of this sample size of 1 million patients and think in terms of number needed to treat or number needed to prevent one 30-day mortality or number needed to prevent one patient from being readmitted, both have an NNT of around 200. And if we translate that into an average hospitalist census and an average hospitalist admission rate and patient contact rate, they could easily meet that NNT in about a quarter to achieve those outcomes. So we'll leave this hospital example and move to the primary care setting. Multiple observational studies looking at a variety of topics in preventative medicine, mostly on a small scale, and some large-scale practices or multi-center practices. Female physicians have been found more likely to provide preventative care more consistently, be current on malignancy screening in their patient panel, up-titrate blood pressure medicines to target doses, consistently counsel on lifestyle changes in addition to recommended therapy for hypertension, diabetes, and obesity, and raise concerns and refer for GU and sexual health topics. Interestingly, in a sample of a few inner-city and high-risk areas, in practices with female PCPs, there were lower rates of teen pregnancy in those higher-risk areas when comparing against male practices with male PCPs predominantly. One example of that summary slide, some performance differences in preventative care. This was a retrospective cohort following patients for about 2 years in 4 primary care offices in Switzerland. The figure here is showing percentage of preventative care according to patient and physician gender. So female patients are these 2 bar graphs, male patients are these 2 bar graphs, female physicians in the white on the left, and male physicians in the dark on the right. To point to physician and patient gender concordance or discordance in terms of preventative care practices. In both columns, or in both female and male patients, women provided more preventative care than male physicians. Again, the bar graphs look fairly close. It doesn't seem like this is all that impressive, but let's translate some of those numbers. Taking from a risk reduction and translating into an NNT translates to an NNT of about 30 for each of those populations, which would be, in a busy clinic, about 1 day of seeing patients, or 2 days. I'll give you 2 days for that, to achieve those outcomes of providing better preventative care. So I've outlined some practice style differences and differences in clinical outcomes. I'd like to discuss leadership styles. And to do that, I'd first like to introduce you to a notable leader in medicine. Dr. Novello was the first woman and the first person of Hispanic origin to be Surgeon General of the United States. She was the U.S. Surgeon General in 1990 to 1993 under President H.W. Bush. Her focuses included preventative measures in HIV, AIDS, and in underage smoking as well. This figure is a bit busy, but I will walk you through it. This figure is from a paper a couple of years ago and has been presented also at several talks by Dr. Molly Carnes of the University of Wisconsin-Madison. She's done a number of papers on female leadership and positions in power, including some challenges faced. So, first I'd like to point out the circles at the top and at the bottom. These are in reference to describing some specialties based on certain types of personality traits. So communal traits versus agentic traits. Agentic traits being dedicated, charisma, intelligence, determined, aggressiveness, fighting to get the work done for the group, competitive, emphasizing rewards for competition. And agentic specialties fitting with those agentic traits are neurosurgery, orthopedics, urology. In contrast to communal traits, being caring, sensitive, honest, understanding, compassionate, and sympathetic, being very concerned with concerns of their subordinates and difficult times that they might be going through. And communal specialties thought to be pediatrics, family medicine, primary care, general internal medicine. And the interesting thing to consider in thinking about these classically agentic specialties having agentic traits and communal specialties having communal traits and attracting those types of people to those careers is thinking about these giant arrows indicating higher status, as well as higher pay in these agentic specialties, and the proportion of women dropping precipitously in these lower pay, lower status, communal type specialties, where many of their traits might be potentially inherent or fostered in those careers. And what does that say in terms of giving these agentic specialties higher status versus communal specialties lower status, and why we're finding more women in those specialties than in the agentic specialties? So in thinking about women as leaders, we've discussed agentic versus communal leadership styles. You may have heard other terms for communal versus agentic, like transformational versus transactional, or collaborative versus hierarchical. They all describe about the same balance of leadership traits that we're talking about, and all used when describing some inherent or noticed differences in leadership style, with women being more transformative, or being described as being more transformative leaders, more collaborative leaders, more communal leaders. The following bullet points on the rest of this slide are some descriptors of communal styles of leadership, and the references indicated both from business world and the clinician world from some observational studies. Oops. Sorry. Some hallmark traits of these transformative leaders include cooperation, modesty, emotiveness, engaging, connecting, and meaning. I think it's interesting to think about those traits and think about those often being dismissed or thought to be incongruent with a strong leader. Women as transformational leaders more apt to generate leadership career paths for their subordinates, for potential leaders, rather than short-term management roles or very task-oriented hierarchical type positions and tasks. In addition, an interactive style that facilitates inclusion and sharing of power and information, as well as centered leadership, providing positive framing to promote achievement in others or the group. Again, these features and from these studies noticed to be kind of inherent or in female leaders when studied as compared to male leaders. So we've just gone through some of the current and potential incredibly positive impacts of women in the field of medicine. But unfortunately, there are still disparities and obstacles which I would like to discuss and highlight. Many people may be familiar with Dr. Kubler-Ross. She was a pioneer and expert in death and dying and grief. Wrote on death and dying in 1969, which interestingly was the year before Title IX passed to do away with gender discrimination in acceptance of students to higher levels of education. And she's a fitting reminder as we talk a little bit about burnout and suicide. This graph is from a Medscape self-report survey of tens of thousands of physicians. And to be clear, the population of physicians responding to a Medscape survey that's in their in-basket may introduce some inherent bias into these numbers that we might not know about. But unfortunately, we don't have a lot of data, so that is why today I'll be showing you a few slides with some Medscape data, and it'll be right there just so that you know and you can make up your mind about that. The simple question for this bar graph was, are you happy at work, and are you happy outside of work? So male physicians on the left in blue, female physicians on the right. This is, are you happy at work? And this is, are you happy outside of work? So we see that people are pretty happy, men and women are both pretty happy outside of work. I know I'm happy outside of work. But we see a pretty significant gap in male versus female physicians happy at work, satisfied at work. In terms of burnout and depression, there are higher rates of burnout and depression in female physicians. To be clear, burnout and depression are distinct entities, but often feed into each other. Burnout being specifically having these feelings and having these thoughts and feeling this way at work and related to work-related tasks, whereas depression being a distinct entity from burnout and not an independent of work. Though I think we've all seen in our careers that they often intersect and overlap. So there are a number of self-report surveys using the Maslach Burnout Inventory, a validated test of burnout, showing increased risk ratio of burnout in female physicians versus male physicians. Female physicians also having higher self-reported rates of depression than male physicians, which is comparable to the general population in females self-reporting higher rates of depression than male, just male in the general population. In terms of suicide, I think many of us are familiar with the increased rate of suicide in all physicians compared to the general population. There is some mixed data in comparing female and male physician suicide rates. And there are higher rates of suicide completion in female physicians than the female general population. This forest plot is from a meta-analysis a few years back on suicide rate for female physicians. It also covered suicide rate for male physicians, but this forest plot only represents studies that looked at female physician suicide rates compared to male physicians in the odds ratio. There's clearly a little bit of publication bias that our eyes can just kind of grossly pick up when we're missing a lot of this area of study. And the odds ratio here is 2.2, which is quite high. But many of these studies and some other ones published since this meta-analysis will highlight a wide range of odds ratio of risk of female physicians committing suicide compared to male physicians, as low as 1.5 and as high as 18 or 20. So we know there's a little bit of publication bias, but there definitely is a little bit of a trend there. And we do know that there is higher rates of completion by female physicians than the general population. Now, I'd like to move on to a fairly shocking disparity in compensation and introduce you to Dr. Bethania Owens. She's one of Oregon's first female physicians. She opened a private practice in Portland. She left her first husband in pursuit of education, and her second husband nearly got in the way of her pursuit of opening her practice, but they managed to work it out. And her quote is, "The regret of my life up to the age of 35 was that I had not been born a boy, for I realized very early in life that a girl was hampered and hemmed in on all sides simply by the accident of sex." Dr. Owen speaks a bit to this point of compensation inequality, and so I would like to dive into that. So, 20,000 physicians across 26 specialties surveyed over 2012 and then again in 2016. The bar graphs, so on the x-axis it indicates how much compensation, and on the y-axis is broken down by specialty, primary care with these top two graphs, and specialties down here. Women in the top and men in the bottom, and women in the top here, men in the bottom. The difference in women is just the difference between 2012 versus 2016. So what we see here, though, is 192,000 as compared with 225,000 in primary care, 242,000 on average compared with 324,000 in physicians in specialties. There are multiple data sets, not just Medscape, that was one of the more recent, but showing an approximately 15 to 20% earnings gap between female and male physicians. The approximate 15% stands up with some older cohort studies from JAMA and New England Journal, and also stands up with the Bureau of Labor Statistics from last year. So this chart was extracted from their annual assessment of workers in the United States from 2016, right here. The responders had to very clearly be working full-time be salaried employees, or be some equivalent of being completely full-time. This was not any part-time workers. As you can see, for physicians and surgeons in 2016, on average, men were making $2,300 in weekly earnings as compared with women making $1,400 in weekly earnings. So why are there pay gaps? There's a few thoughts on this discrepancy that come from a joint committee of some members of Congress reporting on economic disparities encountered by women in the United States. And we'll walk through a few of them. So thinking that they're more likely to interrupt career to care for children, working mothers often pay a mommy penalty, coined by sociologists either in comparison to mommy penalty and daddy praise, but also coined in terms of working mothers encountering some disadvantages systematically, more so than their female colleagues that do not have children. In addition, women are more likely than men to be primary caregivers of other family members, so maybe not just their children, but a sick relative. They're underrepresented in leadership. They're not receiving equal pay for equal work. Women tend to study in lower paying fields. Not quite exactly what we're thinking in terms of pursuing a career as a physician, but thinking back to the communal versus agentic specialties, and potentially pursuing study and pursuing careers in lower status fields. I've chosen to talk next about career and leadership opportunities and the availability to women together, because they are pretty related in terms of pursuit of career and then subsequently pursuit of leadership opportunities and some barriers that are encountered. Dr. Ann Preston is talking about our leaders and potential leadership opportunities. She's the first female dean of a medical college, the Women's Medical College of Pennsylvania, which actually turned out quite a bit of women in the 19th century who were pursuing careers in medicine. In thinking about career and leadership, women and men seem to have some different career trajectories. I think we've all seen some variation of this on the left. It's a woman who's working who also has children, and she has quite a bit on her plate. And I think we see a lot of those cartoons. In contrast, when looking on the Google to find juggling male physician or something to that effect, you see a little bit of a disparity in terms of what the male physician is juggling rather than the female physician. I think there are some internal perceptions and external barriers that impede this pursuit of career and leadership. Career or leadership opportunities. One factor highlighted by this graph is women feeling like they need to work part-time to achieve that balance, to achieve that juggle, and to feel successful both at home and work. So this survey highlights a difference in year, not that different, but, and then percent of men versus women working part-time. So male physicians on the left, female physicians on the right, male physicians on the left, female physicians on the right, just a span of a year. And you can see pretty clearly that women are working more part-time than men. So why this sensation that I need to work part-time? Well, there's some disparate home responsibility. Part of an internal perception and ownership of that responsibility, the perceived sense of greater responsibility, some put on self, some put from other people, from gender dynamics, gender roles. Female physicians report more time spent on parenting or domestic responsibilities compared to male physicians. There's also self-reported sacrifice of career goals or career advancement opportunities. And as I mentioned, gender roles and spousal dynamics certainly playing a role in that as well. Interestingly, female physicians have a higher divorce rate than male physicians. Looking at some external barriers, women often feeling penalized for pursuing a work-life balance by a system or the place in which they're working. There's often a lack of recognition systemically of challenge and importance of work-life balance in physician careers. There's lack of strategic mentoring. There's lack of support for balance in institutional policies and practices, discouraged flexibility in the work schedule, and often an inherent culture of career expectations. I would highlight too that while I've presented these as external barriers, a lot of these principles are sort of indoctrinated into us and indoctrinated into our internal perception through our training. Shifting a little bit to how this trickles into leadership in academia. There are significant gaps in academic leadership. This is AAMC data of leadership organized from top to bottom in terms of higher positions of power in academic leadership. Despite that nearly 50% of grads are women from medical school, from residencies, there's quite a bit of underrepresentation in the top tiers of leadership of women. PBMC residency stands out and stands apart from this, in that we have 61% of our general medicine faculty are women, and 75% of senior leadership are women. The next graph I'd like to walk you through, these are Kaplan-Meier curves comparing time and years to promotion between men and women in achieving associate professorships and full professorships at the Mayo Clinic. So on the left is the percent achieving associate professorships, on the right is full professorships, and this is years of service over time. Women are the bottom line, men are the top line, and similarly with this graph. Despite more proliferative publication noted in this trial, there is less appointment to associate professorships and full professorships, so there's still the gap there even after 30 years. They do eventually get there in some areas, but there's still a pretty significant gap, despite in some cases having more advantageous CV. I hope that I have convinced you of a few points in which women have been impactful in the field of medicine, both through learning of some female pioneers as well as on the group level, in terms of modeling inspirational practice styles, demonstrating superior performance in clinical outcomes, and transforming and communal leadership skills. I also hope I have provided some information in some alarming areas which women are still not recognized nor appreciated as much as male counterparts, notably in compensation inequality and leadership, higher burnout, depression, and suicide rates, unequal pay for unequal work, and both internal and external barriers to this. But how can we maximize these talents, these skills, to help our overall medical community? I'd like to close with a few action items to consider at both the system and individual levels. System factors in terms of offering leadership skill development, implementing and encouraging policies supporting work-life balance, strategic mentoring, role models, encouraging pursuit of promotion, providing recognition, opportunities, and resources, and addressing conscious and unconscious biases at the system level. Hey, if you're not hiring a lot of female program directors, why don't you take a look at the hiring committee and see, is it all men? Are there some women on there? Do we have also a good balance of ethnicities? Some individual factors including promoting your own self-pursuit of leadership, the lean-in phenomenon, engaging a little bit more energetically, being more rigorous with career pursuit. But factors that it's not exactly easy or next to impossible without system factors in place. And then recognizing and shifting some of those internal perceptions, again, with the support of the system. Thank you.
Thanks, Dr. Schultz. I think she gave us a lot to think about. Questions?
I had a question about the compensation issue. since physician compensation has been very historically and still is work RVU productivity driven, and there is no difference in work RVUs, male, female, in terms of the coding, et cetera, how do you make the claim that there's not equal pay for equal work when there's no difference in the reimbursement rates?
Well, I think, so the question is how to make the claim of disparate compensation when it's largely driven by RVUs or performance measures. I think we have pretty clear data that over the last 25 years, multiple studies that have shown while we've been in this RVU generation productivity model of compensation, that there still are gaps, and not just self-report survey gaps. I don't know exactly why that might be, except to say that some of the papers commented on some lower base salary. So everyone kind of starts with a base salary. It's not 100% RVUs. It's not 100% productivity.
On the same lines, I find the mathematics doesn't work. If you have a woman and a man in private practice, what's the difference there? It must be, there's only one thing, and that is that women see fewer patients per hour, still with the same code.
So the question or comment was, so if women and the math's not adding up in terms of women seeing fewer patients per day, and that is completely not true. So again, I did point out that, you know, the Medscape data was a self-report survey, but that difference, that 15-20% difference, holds up from older trials in the 1990s as well as the labor statistics trials where they matched clinical practice, hours worked, number of patients seen, patient acuity, and showed less compensation.
Does that mean that the women didn't have the same, collection rate? Or, what was actually measured? So there's something wrong with that picture.
I agree. There is something wrong with that. And so the papers did not point out, I think what you're getting at is this coming from reimbursement from insurance, reimbursement from Medicare on that end versus reimbursement. Okay, then I'm misunderstanding.
It's a sexless thing. Insurance companies pay the same. So if you're seeing the same number of patients per hour with the same coding, you should be getting the same amount of money.
That is true. What we're seeing is not that.
By the way, I went to a women's medical school in England called the Royal Free Hospital. The women didn't seem to have that problem there.
Yes.
I think that the issue is probably that there are more women in these studies, or it's a question that have leadership positions that are paid more, like more CEOs maybe.
That women are more likely to be CEOs? I'm sorry.
Have leadership positions in addition to whatever seeing patients, because I agree with you, there should be no reason why reimbursement is sexist. I mean, that's not possible.
Yeah, and again, I think like salary-wise, it's not 100% reimbursement, and that I believe that where the disparity comes to light is the kind of base salary. And there's certainly regional differences across the country, but the female to male gap kind of stands up. But it could be that they are working full-time but might have an alternative practice or leadership position, although we've seen less leadership positions, but potentially doing something else in terms of their non-clinical work.
There's a graph that you showed where the question was, are women happy at work, outside of work?
Mm-hmm.
It seemed like the percentages of the responders, of female responders, didn't add up to close to 100%. So could you explain that?
Oh, sure. We'll go back to it.
I think the male responder added up to 99, something like that.
This one?
Right.
Okay. Oh yeah, 26 and 60, 86. You know, I'm not sure. Oh, it was two separate questions. Two separate questions. Oh, sorry. Her question was clarifying that um, um, these graphs, the blue and the blue and the pink and the pink, do not add up to 100% each. But the survey was, are you happy at work? Question. Are you happy outside of work? Question. Yes.
So Louise, that was great. I can't help but reflect that, gee, over the last 45, 50 years, my medical school class had one woman. I lectured to this year's medical school class, and it was 65% women. So are you optimistic or pessimistic? Seems to me we're moving in the right direction.
I am optimistic. I'm optimistic based on a lot of the earlier parts of my talk in terms of leadership style, practice style, and the general movement and trend of women into the workforce. I do think, though, as your comment about 40 years, so in 1970 is when Title IX passed. There was about 14,000 women in the U.S. before that, in the prior 30 years that had graduated medical school. And then in the decade after Title IX, there was 20,000 female graduates. And so I am optimistic. What I'm a little bit pessimistic about is that was 1970 to 1980, and it's 2017, and we're still seeing some of these gaps. And I think some of that is trying to be very cognizant about recognizing some of those biases, inherent biases, unrecognized and recognized. But I am hopeful in the sense that women continue to show that we belong here, and sometimes we're doing a better job. Yes.
I have a feeling we're not raising good men in this country because I think men are getting to be lackluster and women are taking over very easily, like you both.
That could be true.
And we're not raising boys to become real men. Who do we blame?
Well, I have to. So, yes.
The slide you have up there brings up the issue of why you already have 33% of people happy in their work, like 26, and the suicide rate being higher in the medical profession at large. You wonder if there are some actions that can be taken pretty immediately, rather than more and more studies to prove this or prove that. And there's a need for people to realize that money isn't the end of what you're looking for in your professional returns, or that shouldn't be a major issue. And in fact, that's what happens to many people. They cut back on their time as they get older in their practices, and they're happier with smaller incomes. Those issues bear very largely on the figures that you've been showing. And I hope people have the courage to do that. Share practices. Work less than full time. Have a little bit more of the good side of it over on the other side of that slide.
So the comment being that the absolute numbers on the "Are you happy at work?" question are pretty dismally low, and the higher rates of suicide are pretty unfortunate in the physician profession. Which, yes, I totally agree and did not highlight that in particular. Yes.
Have you seen any variance regionally with some of these gaps or some of these rates? Are some parts of the country doing a good job at promoting things and others are not?
Yeah, there was, I'm blanking on which institution. I'm thinking of Wisconsin, but I think I'm only thinking of that. So his question was related to, are there areas of the country or places that have put into practice some of these positive things or some of these features to help promote some of that? And actually, I think I have in my reference list at least. UC Davis, that's what it was, UC Davis in California. Their School of Medicine kind of took on a more systematic, about 10 years ago, they took on a systematic approach to recognizing, boy, we don't have a lot of women or actually ethnicities, a variety of ethnicities in top tier positions in their medical school. Why is that? Well, let's figure this out. Let's try to adjust what our hiring committee is very strategically, and so they did. Let's also adjust our mentorship tracks and our role model and our mentoring programs and strategically target women leaders within those classes as well as within the faculty departments. And they had pretty great success rate. I think changing their leadership positions from about 20-30% female to 40-50% female, as well as coaching some of their medical students in certain career paths more geared toward leadership positions. I think I'll go in the back and then we can come back to you since you had a question already.
I just have a quick, I guess, maybe comment or question about the salary difference between the men and women. Was it adjusted for age and time in practice?
Yes.
Okay.
So not every, again, we're talking about, probably a dozen or so studies in the last 30 years. So some of them certainly were. The Bureau of Labor Statistics is a little bit tricky in that they don't necessarily dive into the nitty-gritty as much as, say, the Medscape survey did, the JAMA survey did 10, 15 years ago, and the New England Journal of Medicine study did like 6-7 years ago. Yes, there are adjustments for hours worked, time in career, are you at 20 years, 30 years, and some of the outcome trials also looked at that as well. Yes.
My question is similar. There are some countries that have better support for parental leave, like fathers can take daddy's leave and whatever. Did you look at any international statistics, how this compares the issue between women and men in medicine?
In
Finland,
terms of
Sweden?
compensation or in terms of like better practices? Anything.
Pay or
Okay.
percent leadership, because I think that's a big thing, that the feminine. In one of your graphs, I think up to full professor there's a lag of 10 years, but then it goes almost parallel, so that means that's probably the time where you had family time.
So the question was related to what is known about in terms of international either success stories from promoting leadership, promoting compensation and equality, that kind of thing, as well as any disparities seen there. So I would say of my reference list, probably about 20-30% is from some European studies. That's the only place where this has also been looked at is in Europe. No other region of the world has, at least that I saw. Now again, I probably missed one or two. And there are a few practices in terms of paid leave. I did not see a ton, as much as I saw in the U.S. literature in terms of academic leadership and leadership positions with a large gap. But I don't know for sure. Yes?
Looking at burnout rates and unhappiness rates, do you have any comparisons of women physicians that have children versus those that do not have children?
Oh, interesting. So question was comparisons of burnout and suicide rates in women physicians who have children versus women physicians who do not have children. No, I don't think I saw that. It might potentially could be in that meta-analysis, one of those papers, but I didn't see anything comparing that.
Well, the hint would be that having children at home, some women physicians might be torn between their duties at home versus their duties as physicians.
Yes, absolutely. I think as we talked about kind of juggling of career and what that means in terms of happiness and career satisfaction. Yes.
When I was a medical student, I read some study that compared women family physicians and their level of happiness as it related to the number of children that they had. And actually more children had higher happiness rates, with the happiest women physicians having 5 children.
So it sounds like most people heard that, but Denise had read a paper that reviewed that women physicians who had more children were happier, and the tip-off point being 5 children. Yes.
I'm hesitant to offer a generalization, but I will anyway. I've been practicing for over 30 years. I've been managing and coaching physicians for nearly all of that time in both private practice and Providence Medical Group. And I think the generalization is that I don't think that female providers, when you look at income and productivity, they don't care as much about the productivity as male physicians, and it's much harder to motivate people on the productivity side, RVU side, and that's my generalization comment from years of experience at many women and many men providers in practice with me and together. I think there are other ways that you can motivate people besides productivity, and there are many things to the practice of medicine besides productivity, believe me. But that's the observation that I would share. And I think that has something to do with the need for what they feel a comfortable level of income is. They don't want to be pushed to the limit as much.
So a comment on kind of anecdotal experience in terms of career and noticing potentially less drive or less motivation in female physicians to achieve some of these goals that were set by someone, the greater entity of productivity and that kind of thing, which I think actually, Dr. Kern, fits in a little bit with this slide in terms of what are we valuing? We're valuing these agentic specialties, agentic traits, these transactional things, higher procedures, blah, blah, blah. And we're putting lower priority, lower value on some of those communal traits, communal specialties. Yes?
Louise, great talk. I have two comments. One is, I think, in tagging on to Dr. Kern's comment, I think women are much more interested in managing a population. And I think population health much better suits what we're about, which is preventive care and counseling and less the RVU drive and productivity drive. And so I think that where medicine is moving very much complements a women's approach to practice as a gross generalization. But more, I think, to the point, as I reflect on my 30 years in medicine, where we have suffered women who think that they need to care for their parents as well as their children, and maybe bear that responsibility sometimes more than their partner. We don't have in the workplace adequate support for child care and for support for how do we help our parents move to Portland or get the care they need in Portland from people within our organization. Yes, we have WeCare. WeCare is not enough for many of us who are in private practice or work for P&G or work elsewhere in the community and admit to our hospital, as well as are struggling to figure out what to do with the sick relatives that we feel ultimate responsibility for, who live here or who live elsewhere in the country. And where I hope Providence goes is that we move forward into the next decade. We can help not only our female providers, but our male providers as they struggle with both being caretakers for their kids and caretakers for their parents.
Thanks. So a couple of comments, one being women physicians may be better or more geared, let's say, to population-based health principles rather than, say, some of these transactional principles. And then the second comment more in terms of the system factors, which we touched on a little bit, of destigmatizing some of that work-life balance pursuit and that sort of thing.
Well, thanks, Louise, for stimulating talk. Everyone.
That's pretty interesting.
Oh, thank you.
Stimulating.
Thank you.
I have one constructive comment.